Okay, there you go. So hi again, everyone. Welcome back to another week of helping you to revise. This week, we are doing the 2013 DP Psych. This is actually different to paper 6. So if you guys might have done paper 6, there are a few similarities between this one and that one, but I've taken those questions out. Okay. So I'll just put that in here because this paper was actually pretty difficult to get definitive answers on, but that's why I'm presenting you with an evidence-based guide. Okay, so for example, first few questions are from paper 6. So if you want answers, please have a look at that video. Okay, question 1. What do we think? So we have a 36-year-old woman. So 36. She has intermittent right thumb and index finger paresthesia. She's currently pregnant. It's worse at night, and it's relieved by hanging her right arm out of the bed. Is it a Bennett's fracture? Do you guys know what a Bennett's fracture is?
It's the opposite of
Could anybody tell me the description of a Bennett's fracture? So this is a first MCP. So first MCP fracture. It's actually the most common metacarpal fracture and one of the most common hand fractures altogether. So typically located at the base of the thumb. And in this case, it would be a very, very good differential. The only reason that the answer here is what we'll choose in a moment is because of some wording in the question that makes that just much, much more likely. Okay, so sorry, wrong question I'm thinking about. Okay, so what do you think she has? Carpal tunnel. Okay, so carpal tunnel. So change in arm posture is something that is known to be a mitigating factor for carpal tunnel syndrome. Our risk factor for developing carpal tunnel is pregnancy, which is why this woman has it. It's worse at night because tissue fluid from the arm becomes redistributed, and at nighttime you have no active muscle pump, so all of that fluid is distributing to that area and is exacerbating that inflammation or whatever processes are going on there at the moment. Okay, so carpal tunnel. Sorry, I was talking about this question. Yeah. So next question. So we have a young female. She's a gymnast, so she does lots of hand movements. She falls, she has a fush, and she has tenderness in the right anatomical snuff box and painful wrist flexion. What do you think she has? A scaphoid fracture, okay? So like I was saying, a very good differential would have been a Bennett's fracture, and I think maybe, do I have pictures? Well, we'll talk about scaphoid. Okay, I don't have pictures, so we'll talk about Bennett's now. So Bennett's is as we talked about, first MCP fracture. Okay, 25% of all metacarpal fractures, Okay, so they typically present with direct trauma to the thumb, and that often is a result of a fush, direct trauma to thumb. Hi. Well, we skipped the first three. Okay. All right. And often they have pain in a similar location as you would have with a scaphoid fracture. So what differentiates in this case is specifically the fact that they have pain inside of the anatomical snuff box. And we'll go into more detail about the snuff box very soon. Okay. And going on. So what is the first picture showing? The anatomical snuff box, and it's showing specifically the borders. Okay, the borders. Right, so the border by the extensor pollicis longus, so you can feel that on yourself. So it's called the snuff box because people used to sniff from that location.
Seriously?
I think so, I'm pretty sure. And you can feel those tendons if you palpate it within yourself. Okay, so the one that is an anatomical position, the one that is more medial would be the extensor pollicis brevis, and the one that is more lateral would be the extensor pollicis longus here. Okay, so those are your borders. The reason it's important is because of the scape. So there's a few things that run inside of the snuff box, okay? What are those things in case it comes up on the exam? So what runs inside? 1, 2, and 3. So we've got radial artery and nerve. And what's the last one? It's a vein. Good thought. The cephalic vein. Okay. So why is it important? So the anatomical snuff box is a location. Ooh, sorry, Hannah. So anatomical snuff box is a location where you have the articulation between the scaphoid and the radius. Okay, so it's that location where you have that articulation. So in an event of a blow to the wrist, it's usually the scaphoid that takes the most force. All right. Now, what is important to know about a scaphoid fracture? What are we worried about? Avascular necrosis. Okay. Now, the reason for avascular necrosis is because the way that the scaphoid bone is vascularized is from distal to proximal. So that means that it's vascularized in this direction. So that means that if you have a crack in that direction, all of this location still has a blood supply, but suddenly this location has lost all of its blood supply, which is why avascular necrosis is a very important problem, because it can lead to arthritis as you steadily get older.
Why would it be any different if it was vascularized that way? I think the other end of it makes sense.
That's true, right? Probably. It's a very good point. But there's a very specific reason for it, so you look it up and tell me. I wish I could explain it to you further. Okay, let me have a look. We'll just leave it at that, I guess. Okay, what's this picture? So if we have a look at the options here, so I've just put in, so I always try to explain things that you might not know about. So on that list, what do you think this is? So I'll tell you, it's a problem with this pulley when this tendon sort of gets stuck under it. So this is a trigger finger, okay? Now we'll have a look at how it looks like on the video. So trigger finger, so the way it's described is a sensation of locking when you bend and straighten your finger. So the tendons, they normally pass through this pulley system, which holds it close to the finger. So that's what the pulley is. So this is the pulley, it keeps the tendon close to the finger. So what happens, so another name for trigger finger is stenosing tenosynovitis, okay? So the cells that allow the tendons to flow freely through the channels like this is something called the tenosynovium, which is what covers it. So tenosynovitis is inflammation of that covering, and it gets bigger. And that usually runs under the A1 pulley. So as it becomes inflamed or thickened, it makes it harder for that tendon to glide through this section. So it makes it more difficult. And when the finger flexes, the nodule gets caught and it causes pain. So if we have a look at this video here, I promise it is a video. 1 sec. I'll try to get it to play. Why don't we do this? Technical difficulties. There you go, play. Oh, you guys can't see that. Okay, so do you see that? So when she's flexing her finger, you notice how right there it gets caught? So you see, when she's moving it up, it wasn't a smooth motion. As she was in that position, it gets caught, and she has to wait for a moment for the nodule to pass through that pulley before she can put it all the way up. So that's why it's called a trigger finger. Sort of like you're pulling a trigger. Can you guys see that? Can you appreciate that? Okay. So that's what a trigger finger is, and it's more or less symptomatic management. So it's a tenosynovitis, and the cause for that is unknown. But usually what you attribute it to is just overuse. It can be associated with it. You can get tenosynovitis, but like in the general population, it's just an overuse injury. Okay. So next question. So we have relative. Oh, whoops. So we have a middle-aged woman, severe, unremitting, burning pain in her forearm and hand, with paresthesia of the thumb and index finger. What do you think this is? This is more or less clear cut. So what gives you severe? So first of all, burning pain is usually associated with what? No, so neuropathic pain. Severe is usually due to some kind of radiculopathy. So this is cervical radiculopathy. So cervical radiculopathy is classical in your head, neck, and arm areas. Can be due to many different reasons. but the burning pain, the severe unremitting nature makes cervical radiculopathy the best option. Okay. Okay, next question. So we have a youngish female. She has distress. She has acute onset of severe dizziness and vomiting. She has developed an associated throbbing headache. Her only medication is the COCP. Jess, would you be so kind as to close the door, please? So we have a few options. First of all, do you think this is an acoustic neuroma? So severe, the fact that it's burning, and the distribution makes cervical radiculopathy the best option. And everything else on that list wouldn't match. Okay? Is there one that you thought, is there one that you were thinking of?
Just wondering whether if it was like a picture somewhere else.
So wherever you get the symptom, it has little diagnostic benefit in localizing the lesion in the radiculopathy. So anywhere in your neck, head, arms, shoulders is indicative of a radiculopathy in that upper section. Okay. So going back to this question, acoustic neuroma, what would you expect? At the very least, you might expect some hearing loss. Hearing loss. Does it sound like BPPV? No. What do you think this is? Okay, bradyarrhythmia, vertiginous migraine. Okay, so not ataxia. Okay, not a CVA, not labyrinthitis. We'll talk about that. Not Meniere's, definitely not Parkinson's. Not a peripheral neuropathy. She's not hypertensive. She hasn't had a TIA, and she hasn't got vestibular neuronitis. Now, just before I go on, what is the difference between this and this? Or is it the same? Who thinks this is the same? Who thinks this is different? How is it different?
I don't know. I just remember reading on the slides and they're two different things.
Yes, okay, so they definitely are, but they are very similar, okay? Wikipedia would also tell you that they're the same, but they're not. So vestibular neuronitis and labyrinthitis are both things that affect the middle ear. So neuronitis, by its name, is inflammation of the nerve, usually CN8, which is your vestibular cochlear nerve, whereas labyrinthitis is your inflammation of your vestibular system inside of your middle ear. So they present very, very similarly. What is the difference between them is labyrinthitis affects your hearing, so you have hearing loss, whereas with vestibular neuronitis, you don't have hearing loss. So that is the main differentiating feature. So vertiginous migraine is the correct answer here, likely. Okay, again, I don't know what the correct answers are for sure, but what it is used, so what it means episodic migraine, so episodic vertigo, I should say, episodic vertigo, in patients with a history of migraine, okay? So that's what vertiginous migraine means. So it could also be labyrinthitis, given the history, but with no other hearing loss, and the fact that it's acute and sudden onset makes vestibular vertiginous migraine much more likely. Okay, so let's do a quick breakdown of common causes of peripheral vertigo. Okay, that's a very important word, peripheral vertigo. So peripheral causes, things affecting your ear, things that are not affecting your brain. Very different causes. So 3 common things: BPPV, Meniere's, and vestibular neuronitis. So we'll quickly, or maybe slowly, go through it. Okay, so BPPV, vertigo that's provoked by movement of your head. Okay, so why is that? Because you have canalithiasis, usually calcium crystals that form inside of your lateral or your central canals. And when you move your head, it can cause some balance issues. So important things to know about BPPV is there's no hearing loss, okay? So it's just due to the displacement of those crystals from the vertical into the semicircular canals, which causes your difference in movements. So how would it present? It would present as a brief or recurrent attack that lasts 40 to 60 seconds or 30 to 40 seconds. So that's what this timing means, how long the episode actually lasts. So it only lasts a few seconds, and usually it has high spontaneous rates of curing by itself. So you don't actually need to do anything, but that can take weeks, can take months. So it can be debilitating. Okay, so how do you diagnose it or investigate it? You do a Hall-Pike maneuver. So when you do a Hall-Pike, if they have nystagmus, particularly horizontal nystagmus, that's diagnostic for BPPV. But what you need to know is that the Hall-Pike maneuver only tests the posterior canals. If you have stones in your lateral canals, you need to do a lateral head turn, which is a bit different. but that is also diagnostic in that situation. Then management is Epley's, which is a little bit different, but I don't know how, to a Hall Pikes, and can be therapeutic in a lot of people. Any questions? I think this really is one of the most important parts to know. Brief recurrent attacks. Okay. Then going on to Meniere's disease. So Meniere's disease, first off, is rare. Okay. So it's not that common. If you get an episode, it can last for 20 minutes up to a few days. So that's how long you can feel vertigo for if you have Meniere's. And that is why that is really important to know that timing. And it's important to ask that on history. How long have you had the symptoms for? Okay. So why do we get Meniere's disease? It's not 100% known, but the theories that exist tell us that it's due to endolymphatic hydrops. So hydrops is an ancient Greek word meaning for water. It's typically used for hydros fetalis, which means edema. So essentially it means excess water or edema or fluid overload inside of your lymphatic or endolymphatic canals. And we know that balance is based on the fluid within those canals. Okay. So diagnosis. So these are actually in the definition, but I put them in the diagnosis to make it easier. 3 things diagnose Meniere's disease. First one is you need to have hearing loss, usually a low frequency hearing loss that reverse back to normal in between episodes. So once the vertigo and things is finished, your hearing usually go back to normal, but over a long course of time, you can have more longer term hearing problems. The second one is the vertigo. So again, we've talked about that with nausea and vomiting especially. And the third one is tinnitus. So this is often described as an oral fullness as well as tinnitus. So those are all of the features of Meniere's disease. Okay. So
up to date says labyrinthitis and neuritis.
Medscape says different. What does it say?
Basically, the introduction is vestibular neuritis is also known as vestibular neuritis, labyrinthitis, neurolabyrinthitis, and acute vestibulopathy.
We'll have to look into it. Because different sources say different things, that's why. But thank you for bringing it up. Okay.
My notes say it's different.
That's what I'm saying. I'm saying different sources say different things. So, for example, Medscape directly says they're different. Wikipedia says they're the same. Up to date says they're the same. So there's obviously, it seems like there's differing opinions, or we're missing something that we need to look into further. So hopefully we will, and I'll tell you about it next week if I find anything. Is that acceptable, Roland?
Yeah, no, I'm not.
Okay. All right. I'm sorry. Okay, so I wanted to talk about the management of Meniere's for a moment because I think it's very important, because often people get, well, they don't get confused, but they use acute vertigo management as management for Meniere's alone. And I think it's important to know that distinction. So for Meniere's disease, there's a few specific things that you can do for Meniere's alone, okay? Not all of these are evidence-based, and none of them have strong evidence with them, okay? So the first one is using hydrochlorothiazide. So I told you that Meniere's disease is usually due to that fluid overload in those canals. So those canals, that fluid also contains sodium and also contains potassium. If you go back to your Year 2 physiology lectures, we know that hearing and those frequencies are dependent on channels, ion-dependent channels. So what this hydrochlorothiazide aims to do is to reduce that endolymphatic pressure by reducing sodium and reducing that water content. So if you're aiming to do that, the other thing that you counsel patients to do is to reduce your salt intake and also for some reason reduce your carbohydrate intake. Okay. Now, definitive control, not everybody gets this, but for people who have debilitating symptoms, what you can do is endolymphatic sac surgery. I'm not sure how it works. And the second one is you can actually do ablation of the vestibular organ with gentamicin, which is interesting. Okay. So now what I was referring to is this. So symptomatic management for any cause of vertigo.
So if you use gentamicin, will they just be permanently
I imagine so, but I'm not 100% sure. Well, I guess it's better than having vertigo.
Right.
You'd probably have hearing loss, but you wouldn't have this spinning room around you.
Would they be able to do any like depth perception?
I don't know. I'm not sure how it works or how commonly it's used. Okay, so then talking about symptomatic management, these are 2 things that are on ETG. Okay, so the first one is prochlorperazine, which is called Stemetil. I think a lot of us have probably heard about Stemetil. What you do need to know about Stemetil is used in the acute short-term setting. You can't use it in the long-term setting because it has severe neurocognitive side effects. I can't remember what they are, but I'm pretty sure things like seizures and cognitive decline that you can get for people who are on it for long term. Okay. Now the second one, if Stamatil is not working and they're also not vomiting at the same time, you can use either diazepam or ondansetron. So these are both from ETG. Okay. So if I was to summarize Meniere's disease, infrequent attacks that last for less than 24 hours with all of your vertigo symptoms, so nausea and vomiting, tinnitus, nystagmus, and progressive hearing loss in somebody who's 30 to 50 years old, as well as a feeling of fullness. Okay. So, all right. So we'll leave that there. Meniere's disease. Oh, okay. The other thing that I didn't mention is, have you guys heard of a medication called beta histine? Yes. It's not, yeah, it's not recommended. So it's an antihistamine agent that back in the day was thought to cause vasodilation and decrease that endolymphatic pressure. But first of all, it's not an ETG and it has very poor evidence behind it for actually working in Meniere's. So I guess know that it exists, but it's not used as per ETG or what I found. Okay. So then going for our last cause of vertigo is vestibular neuronitis. So an abrupt onset of severe vertigo, nausea, and vomitus without any hearing loss and no tinnitus. Okay, so it's usually inflammatory. It can last for days. Okay, which again makes it different from Meniere's or BPPV. Usually secondary to another viral infection. So ERT. So after having ERT, then you have this sudden onset of bilateral non-positional vertigo with hearing loss. With vertigo that's lasting for hours to days. So again, usually due to inflammation of cranial nerve 8, and the management, although I haven't given it here, so Stamatil to reduce those vertigo symptoms. You can give prednisolone in some cases, but I'm not sure what the indications are to decrease that inflammation. And from what I found, but again, we've talked that there might be some controversy surrounding it. Labyrinthitis, from what I saw, causes hearing loss, whereas neuronitis does not, but we need to do further investigation for that. Any questions? So the one thing that I stress to you again is this time frame: BPPV, short-lasting; Meniere's, long-lasting but infrequent; neuronitis can last for days. So we'll skip that one. Okay, so now that we've done this, so we have 46-year-old woman. She has dizziness. Symptoms began acutely when she rolled over in bed this morning. Dizziness occurs intermittently, and she has no hearing loss. What do you think she has? BPPV, a pretty clear-cut case, right? Okay, next question. So we have a here, oldish man. He has dizziness. He feels off balance when walking. He has a stooped posture and a lack of arm swing when he walks. What does that sound like? Parkinson's. That's definitely Parkinson's, and maybe another day we'll go into more in depth about that. This is just a joke I saw on Reddit, which I thought was really good.
That's so bad.
Okay, so moving on. So we've now moved on to vertigo, to another question set. So an epidemic that began in 2008, a single booster dose of the adult formulation of this vaccine is recommended for all adults planning a pregnancy, for parents, and for grandparents and other carers. What do you think this is? This is definitely pertussis. So
why don't you wait for after delivery of infant?
So okay.
As soon as possible after delivery.
As soon as possible.
But
That's for the carers, but for the mom, you usually give it between 28 to 32 weeks.
yeah, but it just sounds like you try to avoid while they're pregnant. Although I don't know what else it could be, but it just sounds a bit weird. Anyway,
Okay, hold on to that thought for a moment, because we're going to talk about immunizations a little bit more. Okay, so in reference to that 2008 outbreak, this is what it's referring to. So this is from health, so the government health website. And what I found is that infant pertussis, so all of the sources were usually from the parent, 55% of cases, or a sibling in up to 43% of cases, which is why this recommendation then came through to give a pertussis vaccination. So if we were to talk about vaccinations in pregnancy, let's talk about it in 3 ways. So before, during, and after. Okay, so before pregnancy is what immunizations do we want the mom to have, or should she have? So MMR, influenza, what else? Varicella. Well, she can. These are immunizations that you should have before you get pregnant. But you can have influenza during pregnancy. We will talk about. Okay. Pertussis. And whatever else. Okay.
Whatever we want.
And the other important thing is, with these vaccinations, so with MMR and varicella, the recommendation is to wait 1 month before you get pregnant again. The only reason for that is there's the theoretical risk because these are live vaccinations. So during a pregnancy, what can we give? We give the flu vaccine as well as DTP. Okay. So both of these, so DTP, usually given in the 3rd trimester, so between 28 to 32 weeks. That's an important piece of information because for partners of a child, so for partners of a lady who is currently 28 weeks pregnant, getting the pertussis vaccine is free for them, okay? For a lady who's 28 weeks pregnant, it is also free for them. So that is why that's important to know. The reason for that timing, so that 3rd trimester timing, is giving the pertussis vaccine in this time of pregnancy has been shown to give immunity to the neonate or the fetus as they're growing and before they're delivered, which is why it decreases that whooping cough in that infantile period. Okay, and after is anything you've missed. Okay, anything else? Make sense? Now, what was your question, Yuki?
No, I'm just saying, because I think there's no contraindication for giving pertussis during pregnancy. But this is a question, we phrased it as we try to avoid it while they're pregnant. So I was like, not sure if it's actually pertussis. But there's reason is that for both parents, as soon as possible after delivery of the infant.
Okay, I see where you're coming from.
But if the 2008 epidemic match, that's fine.
It's definitely.
It sounded very weird.
Okay, so Yuki's saying the wording of the question is a bit odd, and it's true. But you can still have it after pregnancy. There's nothing wrong with that. But you do recommend it. You do recommend it in the 3rd trimester, as long as we've got that clear. Yes, pertussis. Okay, next question.
Is it DTaP or just pertussis?
Yeah.
You give DTP.
Okay.
So, okay. So live vaccine, polyvalent vaccine, prevents fetal defects of deafness, cataracts, and congenital heart disease. What do we have here? Rubella. Okay. So we've done this to death already, but here's a summary table that I got from PassMed that is comparing between the characteristic features and other features. So rubella specifically has your sensory and hearing loss, toxoplasmosis and CMV. I mean, this is really hard to say. I mean, both of them are still really similar, but CMV is more periventricular than toxoplasmosis, which is just intracerebral. And you have all of these things, but really it can span any of these conditions. And remember, all of this is available on the mixtape online. Okay, so next question. So recommended to individuals who are immunosuppressed and to pregnant women. So what do we have left? So remember, what did we say we give during pregnancy? DTP and influenza. Okay. Okay, young boy, 3 centimeter, tender left breast lump under the areola. What should we do for him? Does he have breast cancer?
Oh, yeah.
Breast cancer? Okay, no, he doesn't. Okay, so what would be the name for this condition? No, not necessarily abscess. Okay, so puberty. Okay, so this could go under the heading of pubertal gyneco. I don't know if I spelled that correctly. Gynecomastia. Okay, the reason for that is this happens to most boys between the ages of 12 to 14 years old. It's just due to hormonal changes, and it usually disappears by itself. So there's nothing to be concerned about. So the answer is reassure. No, not mastectomy. Okay, next one. So this is now a bit more difficult, and trust me, and nearly everything after this was now another of those journeys that I told you about last week. Okay, so 30-year-old, she has an acute right upper outer quadrant breast lump. Lump is 4 centimeters in diameter. That's a very important number, by the way. Fluctuant, non-tender. Remainder for examination is normal. You aspirate 7 mils of straw-colored fluid. Okay, first question, bone scan, what would we do it for? cancer, specifically cancer that's done what? Metastasize. Okay. Does anybody know if it's Medicare subsidized or not?
I don't know.
No. Okay. Breast ultrasound. What would we do that for? Yes, for here. Okay. So this is diagnostic. We'll talk about specific indications. You guys need to know these indications, which is why I always drill it into you to look at the guidelines. I finally, okay, maybe we'll just go on. Okay, I'm not going to ask you questions. The answer is breast ultrasound. So, oh, that was a very good animation. Look at this animation. Whoa. One more time, okay? Last time. Whoa. Okay. So all of this information is from a really, really good report that is directly from here. This is actually a hyperlink, so you can just press it, I think. So press it. And where is that from? That's from Cancer Australia. So very good validated resource. But that tells you, so this is a GP toolkit for how to investigate a new onset breast lump or concerning breast symptoms, something of that nature. So one, history and clinical exam. So it's not that one, potentially that one, because the most common benign breast lesion in this age group is fibroadenoma, which also sort of fits in what we've found from here, except for the fact that it aspirated the straw colored fluid, because fibroadenoma is usually a solid tumor. So it could also be fibrocystic disease, which is again another hormonal change. Could be many things, but at the very least, it doesn't sound too concerning. So that's why it could also be that, not that one, and not that one. Okay, so what do we do next? Whoa. Okay, so next we do an ultrasound or mammography. So how do we know which one to do? And I'll tell you soon. Okay. Okay, so we know it's benign, and after doing imaging, then we do an FNA. Okay, all right, and that is why I highlighted this question, because what is odd about this question is that it's asking us to choose the best option, but she's already had a fine little aspirate. Okay, which is kind of odd in that diagnostic timeline, because I think a good option here would have probably just been cytology. So cytology would have been a good option because that's what you would do logically after an FNA. But from this option list, breast ultrasound is the best option. So now we're going to talk about mammogram versus ultrasound. Oh, have you guys heard of this, the triple test? Yeah. So say this in your OSCE for sure. Ultrasound, so imaging, right? Imaging. Which imaging do we choose? All right. One, ultrasound is more sensitive than mammography. That's because mammography is a screening test. MRI is not recommended for any new onset symptoms. A mammography is done after an ultrasound, but again, we'll talk about the specific indications. Okay, so if you're less than 35, and in this question, I think she was 30. So ultrasound is recommended as the first imaging modality. So thank goodness we actually have a definitive answer. Next one, if they're over 35, you should do both. Now, the reason for that is mammography can look at the whole breast. It can look at different things. And if you looked at that table before, that flow chart, it said that if mammography is due, that's something that you should do first anyway. But ultrasound is always diagnostic, and that's why you should use it together.
So she was 38.
She was 30. Yes. So if she was 38 years old and she hadn't had, no, actually, no, sorry, that still wouldn't. You do both, okay? If she was 40 years old, because 40 is the cutoff for normal mammography screening. So if she was in that age group, you would do mammography first. But if she was in that interim, you do both.
But would it be, what would the answer?
You would do mammography plus ultrasound.
But what would
What's
come
the
first?
answer to the question?
What would be the next step?
Mammography.
Ultrasound, I'll probably still say.
Okay.
Okay, but I don't know, it's a hard question.
Let's start with mammography.
Okay, so to answer the question about biopsy, okay. So core biopsy is the investigation you choose when you need additional information. So that would be if you had a ultrasound and it showed potentially invasive disease, or it showed multifocal disease, or you weren't sure what the actual diagnosis was, a biopsy would be recommended in that case. Okay, so for example, you're asking tumor type, the grade of the tumor, and receptor status. So I wish I put in a screenshot of something that my reg gave me in breast cancer clinic, but this is really important in the staging of breast cancer, is knowing the receptor status as well as the type of tumor. Because, for example, if it's invasive or pre-invasive, that can decide what kind of management you're going to do. If it's multifocal, that's going to decide if you do surgery or not. So it's very important. Okay. Core biopsy is also important. And this is what I was referring to before in that question. For some reason, she's already had an FNA. All FNA should be sent for cytology. But as we can see in this question, you still, in some situations, you will need a core biopsy because that will tell you whether that cancer is staying in that same location or if it's already invaded into other tissues in that area. Okay, so surgery, so referral. So there's a lot of things here, but I guess the gist of it is if anything is abnormal, call a breast surgeon. So I remember from my GP2s last year, he was telling us that a breast surgeon will see the patient essentially the next day if they have concerning breast symptoms and if you actually think it's breast cancer. So never be scared to call the breast surgeon. Interesting thing, so we talked about the triple test, remember on that page before? So the triple test, when done properly and done all together, has actually been shown to detect over 99.6% of breast cancers. So that's pretty good, 99.6. All right. So I'm gonna leave it there just for a moment. Just give me, I just need to go pray quickly. I'll be 7 minutes or maybe more. In the meantime, I will leave you with a auscultation, if I can find one quickly. I apologize again. Thank you for being patient. And is that okay?
Yeah.
Okay, I'll be back very soon.
We'll have some activity time.
Yeah, activity time. Do you guys want Uno? I have.
Let's go, Taha, go.
Okay, I'll be back in a few minutes.
You know.
Yeah, just play a Monopoly instead. Oh, I can Monopoly from travel.
Yeah, still have enough.
I would have won that game, seriously. Yeah. Still thinking back on it, I would have still won on that.
Monopoly is one of the worst games to play.
How can you say that Monopoly after?
Because I would have won the game.
You were there.
I wouldn't say that. I heard about this.
Hey, Yuki, want to play Monopoly?
Yeah, let's play Monopoly.
I have Monopoly at my house. You want to come to my house?
No.
I was the
Sign me up,
one
sign me
who
up.
was the last place.
If you want to keep your friend, they'll put it on the fridge. I'll tell you that.
That is like the only board game I have.
I still remember my main favorite money.
I've been to someone else to explain
I've
it.
never touched it.
I don't think it's
Cancers.
No balls. Literally no balls.
Maybe this is it's not
Have you
gone away.
Are you going to this?
Yeah. Yeah. I'll open.
No,
Yes. Huh? What? I have an oven.
So I guess I
You're a tool. I agree with that.
lucky
Sharpest toys and shit.
It's very soft shit.
Came down.
Do you know what we are eating? Do we know what we are eating?
I don't know. Olivia just walked up to me like, "Are you coming with us for dinner?" I was like, "Who's off?"
Who's us?
And she's like, "Me."
Oh, yeah, tomorrow.
Invite Taha.
Make sure you
really come.
That's the
Yeah, it's 5.
And we need to
Well,
find
it's
the
fine.
halal
Right.
rice.
Sorry, change the application.
Will Kirby come?
Just
Will Taha come?
Uh,
Well, Yasmin's not coming because
If
she's
you
in.
do that, then.
What's she doing?
I don't know. She's probably being a little bitch at her own house.
Why?
I don't know.
What?
You never seen this one?
Oh yeah, happy birthday for yesterday. I'm only a day late, but happy birthday.
I don't get it.
Wait, what? Wait, what?
Oh, I've seen that's a secret. Everyone's.
No, it's not. I think I've seen this before.
It warms my heart. Thank you for sharing that. Yeah. What was I looking for?
I think I have like 50% at the moment, but we'll give it a chance.
It's okay, I'm on past medicine. It just tells. I just get like 50%. It's like I might as well just be guessing.
I wouldn't have used it.
50-50.
I'm just over 50%.
Oh, we look at the
That's like me on past medicine.
Don't worry, 40%.
No, but the thing is, it says I'm below average and it makes me sad.
But past
medicine-
medicine,
Medicine is so
Oh.
fucking hard. I'm always like under 30 and 40%. Permanently.
and it's like
Okay, I have a better average than you. I have like a 50% average.
Okay, good. We get it.
but
I thought I was doing bad.
it's not a good UK thing.
No, but some of them are relevant. I don't know how to get rid of the
Just
question.
ignore
I just like
anything.
I just do the red thumbs down.
Just ignore anything that I just flag it. I ignore anything that has to do with like CSD, special screening.
Or like law.
Yeah,
Sometimes
probably should study.
They're
going
also
then
like
instead of
follow the
randomly
nice
guessing,
guidelines,
like,
which sometimes might be
percentiles.
different to what I actually follow.
I just like every time
There's like the
I look at,
asthma one,
models,
which is like they
it
just
works
want
out
to
like,
go straight after
mini, mini,
ICS
Okay,
for
so
the
that's a long-
asthma.
yeah,
But
whatever.
here they don't use montelukast, they use lavas. They only use montelukast because it's cheaper for them and good proportion of patients want to. I had to read it up because I didn't understand why.
Wait, what? Say that again.
That's what guidelines, yeah.
In the UK, they use montelukast after ICS.
Seriously?
To step by the approach because montelukast is pretty cheap for them and it's like 50 cents a tablet or whatever.
In Australia, it's like
Like $14. I looked it up, it was like $14 for like,
what pub?
no, it's a tablet, montelukast tablet, it's like $14 for like 20 tablets or something. It's pretty,
Yeah, but when they give it, isn't it like after
you don't give it to adults.
the children?
Because I remember
You give it to children, but you don't give it to adults. But in the UK, montelukast comes after ICS.
Oh, are you saying that in UK adults get montelukast?
Yeah.
ICS?
Oh, I'm
But in kids, it's like montelukast is like the first line almost after Saba.
Yeah, it's after something.
what diuretics like
That's
just very close.
I just heard potassium.
Thiazide or Luke?
Thiazide, because Luke goes with thyroid.
Loop diuretic is
Luke gets rid of potassium.
Luke gets rid of like everything.
Yeah. Wait, what?
Sodium,
Are you asking for
potassium
hypo
chloride.
or hypo?
hypo.
Hypo, isn't that Luke and thyroid? Oh, no.
Luke has thyroid, but which one's more? Because both of them are a possible answer.
Oh,
What's the question?
I remember doing this question. I do not remember the answer.
What's the question? Which one?
I remember knowing the answer at one point in my life. I feel like it's more Luke because the problem is wait, thiazide
Yeah, I thought it was thiazide as well.
to get rid of potassium.
Yeah.
I mean, it does, but
It's not maybe, like, it's not something really used for like
No.
ACE inhibitor.
Really? ACE inhibitor was hyper. Like my GP literally told me it's pretty funny. She's like, oh, I'm giving you a drug for ACE inhibitor. Yeah, Paul will tell you about it, and then first you tell her about side effects, and afterwards she's like, oh, when you try to sell a drug to patients, don't start with the side effects. I was like, oh yeah, we need to take you back in a week because we need you to eat your fat because it can cause renal failure. And she's like, yeah, like you know that, but don't start with that next time.
I just sort of said,
You just start the mid stuff. Oh yeah, it's a really good.
for hypertension.
Yeah, you say, oh, it's a very good drug. It's been around for 30
But the
years.
best,
Very good side effect profile. The most common side effects is cough, but if you do have that, we can place another drug. There's also a very, very small chance that you can use
the best
You
thing
say-
is when
you say
the
four
GP
things.
asks you a question, but they don't know the answer themselves.
It's like 4 things you meant to say. It's like it's cardioprotective, it reduces blood pressure, it's renal protective, and it's
You say Spiro.
Ask me like the
Ace.
Yeah. I'm that Spiro and that took
and it's
renal
mild
protective
diuresis
way.
as well.
Anyway, but that question actually bad. Like, it's not because like
What?
saying the most is like anti-private.
last week we talked about.
I just remember, like, me lots.
It'll be a spironolactone.
Yeah.
I feel like it is thiazide because I remember thinking, Luke, you better work earlier in the chain, and they basically should get rid of more sodium potassium,
Oh,
right?
okay.
Because I worked earlier. But then I remember it was contrary to what I believed.
Believe in yourself.
But then it might be contrary to what I contrarily believe right now. So who knows?
I was always like, that's how I learned it.
Just say that.
You hear what you want to hear, guys.
I guess I'm not looking for the ones here.
You know, are you okay? They were listening.
Was it? Oh,
Are
okay.
you okay?
Okay.
Okay. Thank you very much for your patience, everyone. I appreciate it very much. It was very nice. Thank you. Yes. I feel even better now that I can see all your beautiful faces. So, going on with the same document. Actually, no, this is not the same document. But I just wanted to briefly talk about the different types of surgery that you do for breast cancer. So, two main surgeries, so mastectomy versus a lumpectomy. So lumpectomy can refer to two things. So a wire local excision. Actually, what you might notice is, if you've seen this question, you see how it says wire? Oops.
It's frozen. There we go.
Oops, where am I going? Okay, you see how it says wire localized excision? Do you think that's a spelling mistake or is that correct?
Probably a spelling mistake.
So it's not a spelling mistake, it's correct. Okay, so you guys might have heard of the word like wire local excision. So wire is still pretty much the same thing. So a wire localized excision is, say you have a patient, how do I do a breast? Okay, pretend that's a breast. Okay, and then there's a tumor located here. Okay, so what the interventional radiologist does is, under imaging, I think it's ultrasound, I'm pretty sure it's ultrasound, they insert a little wire into that tumor to show the margins, so that when you excise that tumor and you send it down to radiology whilst the patient is still on the table, the radiologist with an x-ray can have a look if you got the wire or not, because then that tells you whether you have healthy margins or not. So that's what a wire localized excision, stop laughing at my breast, okay? So that's what a wire localized excision refers to, okay?
Isn't this being recorded?
I'm sorry. I'm gonna get banned again. Okay. So unconserving surgery, so a mastectomy. So why do we usually do a mastectomy? A large breast cancer. So that's why. So 4 centimeters isn't necessarily for breast cancer, but it is definitely important for chemotherapy considerations. But at the very least, more than 5 centimeters is usually a relative indication to do a mastectomy rather than something else. But what is most important is if it's multifocal disease. So if you have more than one type of cancer, or if you have cancer that's invading to different areas, mastectomy should be the best option. Okay. Now the second one, the lumpectomy. So if you only take out a small part. So rather than talking about indications, we should talk about contraindications. So if the patient has a small breast, it might be difficult to do a partial mastectomy in the first place. If it's more than 5 centimeters, multifocal diseases we talk about. If they've had radiotherapy in the past because of breast cancer, you can't do a partial excision. I don't know why. Actually, no, I do know why. So with those kinds of things, often you can have micrometastases, which is one of the reasons why we do radiotherapy. So there's always the risk, if the breast cancer has recurred, that it's going to be a more severe version of breast cancer than it was in the past. So that's why recurrence is always a bad thing, because it's usually more severe than before. Can't have. Okay, so if for some reason you can't have radiotherapy, I think one of those reasons, no, I'm not going to give you false answers, I'm not sure. Look up what contraindications for radiotherapy are. If they have one of them, you can't have partial lumpectomy, because with a lumpectomy, they usually go on to have either radiotherapy, chemotherapy, or both. And we've talked about that in the previous exam. And not in pregnancy, if they have positive margins, and what that was saying down at the bottom was after a lumpectomy, you need to have radiotherapy. Okay, sentinel lymph node biopsy. So pretty much everybody who goes in to have breast cancer surgery will have a sentinel lymph node biopsy. So this looks for what the axillary status is, if there's metastasis to there or not, especially if they've had a positive sentinel lymph node. You can also have things like axillary clearance, and sentinel lymph node biopsy is the best version of a axillary staging, but I think axillary clearance is a bit different to a sentinel lymph node biopsy. And there's a few special things. So I think breast cancer is a very important thing to learn about, because you see it so commonly. And if anybody of you at the moment on Gen Search? No? Well, if you were, that would be the best place to see breast cancer surgery, and then all of this will be cemented into your memory forever. Okay, so going on to our next question, we have a likely postmenopausal woman. She has non-cyclical mastalgia. If it was cyclical, what would the answer potentially be, especially if she was younger? Fibrocystic changes, because fibrocystic changes is cyclical mastalgia due to hormonal changes. So that's why it usually comes with the onset of a period. Breast examination reveals a upper outer quadrant breast tenderness with no specific lump. She has a single left axillary lymph node palpable. What do you think she should have? A mammogram, okay? So you don't want to jump to one of those biopsies because from that flow chart, you always do imaging first, okay? Because she's more than 35 years old. Remember we did, there was a very specific indications? So what I was saying, so if the under 35, ultrasound. If the greater than 35 is ultrasound plus mammogram. But, yes, but the thing is that normal screening for breast cancer starts at age 40 with a mammogram, right? And another thing that you guys should have seen there was that the first investigation is a mammogram if it hasn't been already done. So that's why mammogram is the best option. But is it 50? Okay, it might be 50 years old. So normal screening starts from 50. And she was 51 anyway. So that's why mammogram is still the best option. Okay, how many mistakes I made? Okay, so we have a young girl. She has acute onset of exudative tonsillitis, high fever, odynophagia, and mild dehydration. What is odynophagia? Good. And dysphagia? Okay. Well, not calm. Difficulty with swallowing. So what might be a cause of dysphagia that is not a cause of odynophagia? Yeah, stroke, cancer, achalasia. So these things won't cause pain, but they will cause difficulties with swallowing. Odynophagia, because it's painful, can often have associated dysphagia as well. Okay. All right. I think like you guys should probably have discussed it with Kirby, I think. Phenoxymethylpenicillin. And how did you arrive at that answer?
So we said this is 1, this is 2, this is 3.
Okay, I meant, okay.
Okay.
So have you guys heard of the central criteria?
Oh, yeah.
Yes. Do you guys remember what's inside of it? So there's a mnemonic to old. Have you guys heard of this old cafe? Well, don't worry about that now. Okay. Look, so old stands for age. Okay. So if they're less than 15 years old and they're greater than something years old, is a +1 point. Okay. If C, so C is for cervical lymphadenopathy, that's another +1 point. If they have absence of cough, absence, that's another +1. Old, what am I after? F. Fever, +1, and E is exudate. Okay, so exudate is another +1. So the reason the central criteria was developed is it tells us what is the likelihood of having a positive culture if I take a swab from this person's throat, for example. So if you score 4 to 5 points, which is pretty much maximum, then it's a 53% chance that you'll have a positive culture, in which case you'd give antibiotics. Anybody who has a score of 2 to 3 gets antibiotics, and in this age group is phenoxymethylpenicillin. Now, I thought, just because of how many times I've seen different types of penicillin, but I never understood why there exist so many types, I thought it would just be useful to quickly break down all of these different types of penicillin really quickly. Okay. Natural penicillins, okay? So that refers to penicillin G and penicillin V, okay? So penicillin G is benpen. What you need to know about benpen is that it's IV, okay? And that's why there's many of these subclasses under benpen. So the way that you change penicillin V is adding a salt to it. So that's why, you, for example, you have sodium, and why you have procaine, and you have benzathine. So adding these salts to penicillin changes how it's absorbed in the body and how long it lasts in the body. So for example, benzathine penicillin is the longest IM injection, and that's another important thing to know about it, is IM. So for a patient who's taking penicillin V, so phenoxymethylpenicillin, if it's, for example, a young child who cannot tolerate an oral tablet, then you can give them benzathine penicillin, which is an IM injection. So that's on ETG, and that's why I went on this quest to find out why. So IV, IM, and so So you see how that one's per oral? So with our natural penicillins, there's 3 routes that you can give it. Benpen is IV. Benzit, well, all of these are also IM with differing lengths of time that it stays in your body. And penicillin V is per oral. All of these are your natural occurring penicillins. And then other common ones, so things like ampicillin is just an aminopenicillin, which has greater activity against things like H. influenzae. And then importantly, so the other members are things like these extended spectrums. So these have anti-pseudomonal activity. So that's why we use piperacillin or tazocin for somebody who has CF, for example. And beta-lactamase resistant, so what's methicillin? So that's why methicillin, that's why we call it MRSA. So methicillin resistant Staph aureus, because these are anti-staph penicillins specifically made for staph. So if staph is resistant to it, that's a big deal, right? Okay. So I know that that's very extra to have this slide in there, but I thought it was useful nonetheless. But I'm just trying to drive home the point of why it's called MRSA. Okay.
Oh, sorry, just a question with the last question about the Centaur criteria. I was on like MedCalc and it said that like even if you get a score of 4 or 5, you just do the swab or like a rapid drug test thing first. You don't treat symptomatically. Yeah. So like, what do you?
ETG.
What do you think? Yeah.
I would say look on ETG.
Okay. Cool. I'll check it.
What's the likelihood of this could
It's possible, but
Yeah,
you
possible.
can't really tell from that stem.
Yeah, so obviously you want to keep them.
See that is why this was created, because with her score will probably be 4 or 5. So she has a 53% chance of having positive bacterial culture, which is why you would give, from what I understand, empirical therapy. Okay. But Kirby again might have talked about this with you. But if she was ATSI, you just give antibiotics anyway. Okay, because they often have more severe symptoms. Okay, so we have youngish male, dysuria, scanty, clear urethral discharge after recent unprotected sexual intercourse. What is his diagnosis? STI is not a diagnosis. Okay, maybe. Okay, chlamydia is an organism. Actually, I guess you could also call it STI. Yes, okay, that's what I was looking for, okay? So they have urethritis, okay? The reason I wanted you to say that is because it's always important to identify what the actual history of presenting complaint / diagnosis is, so that you can search the correct thing on guidelines or Google, because it'll help you a lot. Because if you just type chlamydia into ETG, you're going to get a lot of different answers. What you do need to type in is urethritis, or non-specific urethritis specifically. So, so in this case, what would you give them? Sorry? Okay, so, azithromycin. What other thing might we consider? Kef? What are we going to choose? Well, okay, we're going to choose azithromycin. Okay, and the reason for that is, okay, so if the patient had gonorrhea, what would you give them is you'd give them ceftriaxone intramuscular plus azithro, which is 1 gram per oral. Okay, 1 gram per oral. And you need to know this in actually quite a lot of detail, because I'm pretty sure this was a GP day. Yeah, this is in the GP tutorials. Yes, and if anything is in the GP tutorials, you need to know back to front. So you need to be able to explain to the patients how you take the medications, what side effects you might experience, what you need to make sure that they don't do. Okay. Sorry? I'm pretty sure it's just a tutorial day on STIs. Like a lady came with STIs. Like, you know how those pretend patients came in? Yeah, one of those days. I'm pretty sure it happened. Okay. So the reason in gonorrhea, so if you just had chlamydia, you just give azithromycin on ETG. But for gonorrhea, you'd give both. And the reason for that is by giving both, you decrease cephalosporin resistance to gonorrhea while you're awaiting these results. Okay, that's another important thing. You need to make sure that you get results. So you can do that either with a genital swab, or you can do a first pass urine, and you can send that off for NAAT, which is nucleic acid amplification testing. Okay, so to quickly talk about the diagnosis in this situation. urethritis equals these three things, okay? So urethral irritation, if you have dysuria, discharge, or if it's asymptomatic, okay? Or cervicitis, okay? Because it can cause both. So cervicitis is either discharge or asymptomatic. So both of these can be just asymptomatic. Okay. So chlamydia, gonorrhea are the most common causes. The reason that you need to treat it as soon as possible is because it can cause severe side effects or severe complications down the line. Those being infertility, for example, due to scarring of the fallopian tubes, you can get PID. Very rarely you can get epididymolysis, or you can get a disseminated gonococcal infection, more common in people with HIV, because they can't mount an immune response. You must do the NNAT, as I just said, and you do empirical therapy until results arrive. No, it doesn't matter. And other important things you need to know is at 1 month, you need to do a test of cure. Okay, so you need to retest them if they've been cured, but you don't do that for everyone. You only do that if you question whether the patient has adhered to medication or not, only those patients. But what you do need to do is at 3 to 6 months, you need to test of reinfection. So that's how it's explained on ETG. So that's for all patients, but 1 month is only for patients that you question whether they're adhering to medication or not. And the other thing is you need to consider whether this is an STI and whether you need to do contact tracing. Once you do contact tracing, all contacts should be treated with azithromycin 1 gram per oral. Yeah. Yeah. Non-sexually. Blood, maybe. Discharge. Oral sex.
Then that is sexual.
Our sex is sex.
I'm not. It's not sex. Doesn't count. Okay.
If you say no,
I'll think about it and get back to you. Oh, ETG. There you go. ETG. Okay, next one.
I did not have sex in that.
So
Oh, yeah.
you're a GP. You're in ED. 55-year-old man. He has urosepsis. That's important. That's why for sepsis we always need to think about three things: blood, urine, chest. Acute bacterial prostatitis. He's febrile, rigor, sweats, dehydrated, not tolerating oral fluids. CRP is high. Renal function is normal. He's allergic to penicillins. What are you going to give him? Why? Okay, so the thing is that you might think this is a very specific question. How, without reading ETG, how would I possibly know the answer? And that is where a little bit of understanding about antibiotics and organisms will help you out a lot. Okay, so the first thing, prostatitis is a type of what? What it's trying is like it's a type of urinary tract infection, right? Something in the urinary tract, anything can become affected. And the most common organism to cause a UTI is E. coli. What are other common organisms? Klebsiella. Okay. Yeah, okay, exactly. That's the point I'm trying to get at, okay? So they're all gram-negative. And what is the best agent that we have for gram-negative? It's gentamicin, okay? Now, so... Sorry? You can give IV gent. Yeah. So, but the thing is that, so you could arrive at the answer that way, but ETG does have a few specific points, okay? Now the first one, so let's talk about it in order, okay? First of all, so acute bacterial prostatitis. So this equals a complicated UTI. That's the best way that you can talk about it. And symptoms equals lots of, so very severe lower urinary tract symptoms. And they'd be very tender on PR. So the prostate, you'd have prostatic tenderness on the PR. Okay. Now, what kind of medication do we give them? So if it's mild, so if they have mild disease, then you'd give them trimethoprim. So trimethoprim, which is something we also commonly use for UTI. Or you can give them augmentin, or cefalexin, okay? So you can give them one of these three. So essentially it's treated as an acute cystitis. So it's the same as an acute cystitis, how it's treated. But in this case, because it's severe, it's treated with gent. And it's treated the same way as you treat pyelonephritis, which is why we're giving gentamicin in this case. Okay. Say it again. Well, the gentamicin is specific for bacterial prostatitis, so that should treat the urosepsis at the same time because the organism is still gram-negative. You give gentamicin plus augmentin in this case, so you give both, but augmentin is not here, so gentamicin is your first therapy. You give both. You give both. But for somebody, but because he has a penicillin allergy, it specifically says you don't give him augmentin. And for patients who have sensitivity to penicillins, you give them gentamicin alone. Okay. All right. And if both are contraindicated for whatever reason, then you give ceftriaxone. Okay, so these next questions are on paper 6. Oh, we're not making good time. I thought we were. Okay, so we have a 75-year-old man. He has heart failure. In terms of follow-up, his blood tests show potassium to be 2.9, which is...
Oh.
Yeah, they're already on paper 6, so they should be on that other video. Okay. Okay, so he has low potassium. So what do you think has caused it?
Yeah.
So loop diuretic, that's correct. Why not?
We were arguing because thiazide diuretic can also cause hyperkalemia. We're just not sure which one does it more.
Okay, so the way to answer that question is by knowing your guidelines. Okay, is heart failure. So this table is from the heart failure document. Okay, and this is showing people who have moderate NYHA symptoms, so not mild. The treatment for mild is actually pretty much the same, but I'm not sure why that's not showing. But this is okay. So fluid overload. So you start them with a diuretic plus ACE inhibitor. So the diuretic is usually a loop diuretic, that being furosemide, rather than the thiazide diuretic, which you might add further down the line. Okay, so that's why loop diuretic is the best answer. Make sense? Okay, so yeah, okay. All right, actually, we need to know a few specific things about this. So it's really, really important that you know your heart failure guidelines. So we always start patients on ACE inhibitors, and this that will be on another page. So ACE inhibitors, diuretics, and ACE inhibitors. So that's usually furosemide. ACE inhibitor can be anything really. So if they're fluid overloaded and the symptoms are not managed on ACE inhibitor alone, and they're not fluid overloaded, then you add a beta blocker. Okay. If they are fluid overloaded, then it depends on what happens to their symptoms. So if it improves, again, add a beta blocker, because if it's improved, that's essentially this pathway. And if it doesn't, if it's persistent, then you have spironolactone. So usually that requires you to have a left ventricular ejection fraction less than 40%, or one of these things. So it really depends on the specific clinical situations. So same old. Okay. Sorry? So the thing is that the document clearly states you need to be stable to be put on a beta blocker for heart failure. Well, fluid overload is a symptom of decompensated heart failure. Okay. So I just recommend reading that document because it's very good actually. Okay. So next question. So we have a youngish patient, is heterosexual male, dysuria, and profuse purulent urethral discharge. What do you think he has? Gonorrhea. Okay. So gonorrhea is definitely the most likely, a very common infection in males, and the fact that it's purulent differentiates it from chlamydia. Chlamydia usually being white, scanty discharge, gonorrhea being purulent. Okay. Next question. So we have a young male, homosexual. He has HIV with a low CD4 count, so which means that he can't mount an immune response. His T cells are quite low. He has these small, white, umbilicated papules that are appeared on his back, thighs, and lower abdomen and groin. They have a pearly appearance to the center. What is that? This is a molluscum. So molluscum, without a doubt. Okay, so molluscum contagiosum. So this is, so what's it due to? Molluscum virus. So it's a type of pox virus. Okay. But the virus is like molluscum contagiosum virus, MCV or something. Okay. So it's benign. It's usually spontaneously resolving. So spontaneously resolves, but it can last for months to years. Okay. And because it lasts so long, this is why some patients opt for cryotherapy to try and get rid of some of these lesions. But there's no other, well, there are a few other therapies that you can use. So there's some creams and such. So one I remember is blistering beetle juice. So that's the name of it, which can help. But there's a lot of different things you can use, but there's nothing curative. Okay. So that's how molluscum looks like. Oh, a buzzword for you guys is, oh, what was the buzzword? I've already forgot what the buzzword was. It's not umbilicated. It's like when you press it in, it has an umbilicated appearance, but it has like a name. Yeah, if only I remembered it. Okay. Anyway. No. Okay. So we have next question. So we have 56-year-old. She became sexually married when she was married 10 years ago. So it's not going to be an STI, is what they're trying to say. She's had a pap smear. Colposcopy reveals cervical cancer. So what does she have? HPV. Okay, not much more we need to say about that.
Oh God, it's small.
Okay. Oh, so this is when the difficulty started. Okay, so we have a 45-year-old. Previously well, 5 days of cough, shortness of breath. He has left-sided pleuritic chest pain. So I'll draw to make it easier for you guys. So right, left. That's correct, right? Okay. So he has pain and he has basal crackles. Okay. If you just saw that on someone's history, what would you think they had? Pneumonia. Okay. And the treatment for, actually, first of all, we need to look at his symptoms. Okay. So it's febrile. So he has hemoptysis. He has a normal blood pressure, normal heart rate, normal respiratory rate, but he has some crackles. Okay. So okay, I'll ask you a few questions. One, antibiotics. Yes or no? No. If so, which ones? Amoxi? Would you give Amoxi plus Doxy or Amoxi or Doxy? Or, okay, or Doxy, okay? So so Doxy by itself isn't as effective as amoxicillin alone. You can give it if they have an amoxicillin allergy. Okay, second one is, do you do a chest x-ray? Yes. Okay, do you do it before or during? So, for example, okay, so there's a few options here. First option is just see a chest x-ray alone. Second option is we can give chest x-ray plus antibiotics, or third option is we can just give antibiotics alone. So which one are we going to choose?
X-ray and antibiotics.
Okay, so that's why I had such a difficult time with this question, because I had different responses from many people. I asked Professor Murtagh, because I'm a GP, I had that opportunity, and he told me in his practice he'll probably do a chest x-ray. Depending on the results of a shared consolidation, he would then give antibiotics. I talked to another GP, my GP that I was with, and he mirrored that suggestion, but he also said that he might also just give antibiotics at the same time and get the chest x-ray for diagnosis. So with such a differing opinions, the only thing you can rely on is guidelines, okay? And then I say that a lot. So if, oh no, I thought I had the, dang it. So if you look on ETG and you look at community-acquired pneumonia, it goes on about different things, diagnosis, evaluation, history, and management. And what it says is that in the most settings, consider, or at the very least, should order a chest x-ray for diagnosis of pneumonia. So based on that sentence, it's probably best practice to do the chest x-ray plus give them the empirical therapy, which would be amoxicillin in this case. Make sense?
Technically, because you can see, like, for example, you can get a typical infection and then a typical pneumonia afterwards. And if you get a chest x-ray in the first case, you can compare like if there's worsening. Like,
Yeah.
For example, if they develop in 5 months. So
Exactly. That's correct. And I mean, I'm not a Professor Murtagh, but I feel like giving antibiotics is probably a good idea. And so, and that is the other thing. So somebody said hemoptysis. Somebody pointed that out. Who did? That's very good. Why did you point that out? Yes. Okay. That's a very important point that Paul brings up. Okay. He's had hemoptysis. Okay. And hemoptysis means that his Welsh score is 1. his PERC score is also, so remember we talked about PERC score, pulmonary embolism rule out criteria. So if a Wells score is 0 or low, you then go on to do a PERC score to then rule out pulmonary embolism altogether. So here's, because of his hemoptysis, PERC score plus Wells score are both 1. But you need to take that with a grain of salt. You need to consider the clinical history. So this patient is well, the resp rate is normal, the vitals are normal, which makes PE very unlikely. Saying that in OSCE, you probably would be reasonable to say you might consider sending them to hospital for evaluation. But with inflammation, you get a pneumonia, having hemoptysis, especially a single episode, is also likely and common. So it's just something that you should think about. You should pick it up, but interpretation of it is also important. So that's what I'm just trying to stress into you. Pick it up of these red flags. Hemoptysis is a red flag for PE, but in this situation, it's probably very unlikely. Again, clinical history is important.
Well, you have to, because you can get a pneumonia of cancer. Anyway,
Okay, admittedly true. Okay. Okay. All right, so next question. All right, so we have a 10-year-old girl. She's had an ERTI from 2 weeks ago. She has a persistent cough, which results in bouts of coughing. She can vomit after the cough, fully vaccinated, attends a school where several of the patients have single-dose vaccines, so a lot of the children at the school are not vaccinated. What do you think she has? But she's had her vaccines. Very good. Okay, so so she has pertussis. So having an immunization against pertussis does not give you lifelong immunity. Generally, it gives you 10 years of immunity. If you have a booster, it can give you longer. So pertussis infection is actually most common in the adolescence plus young childhood category, but it's most severe in infants, so people less than 1 year old. So that's why it's really important. So the second thing, again, I need to ask you, 1, do we need to do any investigations? What investigations do we need to do? Nasopharyngeal. Why do we need to do that? Why is diagnosis important? Yes, so I heard a few people say, so it's notifiable. So you need to notify the department, okay? The second thing is, do we treat it?
How long has it been?
Depending
2 weeks,
on
yes.
a few things.
What things?
If it's within 21 days, I think you still need to give them antibiotics.
That was 4 weeks.
4 weeks? No, I don't think it's 21 or 14 days.
I think it's 21
14 for context.
I had
After the cough.
I actually had someone walking with pertussis.
So I think what you might be referring to is that after 21 days, somebody with pertussis is no longer infective. So the pertussis is cleared from the nasal secretions. So therapy, if you give it early enough, so if you can give it in less than 2 weeks, so less than 14 days, it can alter the course of the disease and make it shorter. Okay, that's an important thing. Now, in terms of treatment, there's a few things you need to know. You need to isolate them from school, number 1. Number 2 is, so you need to isolate them from school for at least 5 days of therapy, 5 days of RX, of therapy, or they've been coughing for greater than 21 days, okay? So that's how long they need to be outside of school for. So if we were to treat them, what antibiotic would we give them? It is azithromycin, and this time I don't have any good reason why azithromycin is the best antibiotic. It just works against pertussis, but a lot of things do. For example, trimethoprim also works, cefalexin also works, but azithromycin is correct. So the answer is I now. So you might be considering, why isn't it H? And I don't have a perfect answer for that. The only thing I can offer you is this, which is what is the difference between a nasopharyngeal aspirate and the difference between a nasopharyngeal swab, okay? So this is a swab. So that's when you put the little stick directly into the back of the nose, you move it back and front, and that's how you get the sample. Nasopharyngeal aspirate is similar, but is different, okay? So you can see you have a syringe that has fluid inside of it. You also insert it much like you insert the swab, but you inject that fluid, then you suck it back up. That's why it's called an aspirate. So that might be more difficult in the 10-year-olds age group. Saying that, however, both the Health of Victoria website tells us that you can do either, and that you still need to do nucleic the NAT. So you still need to do the amplification test, regardless whether you treat them or not. So that is why I still can't tell you for sure if the answer is this one or if it is this one, but my feeling is that I is probably the most correct.
alter the course, but if you can't alter the course after 2 weeks, then why would you do it? Although this is like right.
This is pretty much at the margin. So it's difficult. I'm not 100% sure, but I do think that antibiotics is the correct answer here.
So it's within 2 weeks of the onset of cough.
Well, the thing is not is the 2 weeks is only giving it in that period is proven to alter the course of the disease. It doesn't mean that you still can't give them antibiotics afterwards. Okay. All right. Also, what is meant by an atypical organism? Just out of interest. But what is the definition?
Can't be cultured.
Something that can't be cultured. Okay, so something that is not gram positive, something that's not gram negative. So as you correctly said, things like chlamydia, things like mycoplasma, those are atypical organisms. The only reason, why did I bring that up? I don't know. Okay. Why did I? So pertussis can be diagnosed on the clinical if the patient has acute illness. Oh, okay, maybe that's why I added it. So.
Yeah, it says
Oh, right. Okay.
LCH, you don't have to
Yeah. So okay. So. Yeah. So I'm not 100% sure if you do need the. I'm pretty sure you do need the NPA though.
Yeah, and it says it's for infection control.
Okay. All right. Well, in that case, infections are definitely a correct answer because this is from health.vic. All right. Which so antibiotics is correct. I heard. All right. Next. Oh God. Next question. So we have a young person. They have acute left-sided chest pain, gradual onset, shortness of breath, appears anxious. All your vitals are normal. What does he have? Anxiety. So you need to reassure him. Okay. So reassure. Okay. So we have a 52-year-old woman. Therefore, she's most likely postmenopausal. We can't know for sure, but it's definitely very likely. All right. Well, it says here, no PV bleeding for 2 years. She has disruptive hot flushes and she has slight PV spotting. So let's go through the options. Would we give COCP? Who would we give COCP? What age would we give COCP? So if she's 49 years old, let's say, okay? Because typically you need to be 51 years old before you don't need the COCP anymore, because you need to have been on therapy for at least 1 year, or you need to have 2 years of no periods at all, which is why 49 is typically when you need to give COCP, because you need contraceptive benefit. Now, that's not relevant for this question. HRT, what do you think? Yeah, we could. So I'll put so IUD, not relevant in this case. She doesn't need contraception. NSAID, she doesn't have dysmenorrhea. POP again, pregnancy, full coding profile, pap smear, STI. Reassure? Would we reassure?
No.
No? Good. Okay. No reassure.
You know,
Okay. Refer to gynecologist for biopsy plus hysteroscopy. No? Would we do a transvaginal ultrasound and assessment of thickness? Why? But it's only a very slight PV spotting.
Still.
Do you want to take that risk, Tapa?
Why would you could just give a HRT? No, you're absolutely correct. No, well done. Well done. No, that's correct. Okay. So if you have a look at, so again, this is another hyperlink. So this is from Cancer Australia. This is a GP guideline for any woman who has vaginal bleeding. So this has peri, post, and pre-menopause. Peri, pre, and post-menopause. So this is a flowchart for that. So let's look at this. So history, what does she have? So okay, that's the thing. So she has abnormal vaginal bleeding. Okay. So if we follow this down, so FBE, we're indicated, it's not indicated here. She's not on tamoxifen. All other women, they require TVUS to report to include endometrial thickness. It's pretty much word for word that option. Okay. And looking further down the timeline, so if the thickness is more than 4 millimeters, that is when you would refer to the gynecologist for the hysteroscopy. Okay. Next question. So we have a young female. She has a past history of an ectopic pregnancy at age of 18. She has migraines with aura, which is a contraindication for what? COCP. Why? Increased risk of stroke. I still couldn't find out the reason. I looked extensively. She requires contraceptive device. She doesn't want further pregnancy. What would you give her? What is this apparently a contraindication for? An intrauterine device. That's why I put air quotes. Okay, it's not actually a contraindication. You can still use it. The only thing is having pregnancy with a Mirena. So again, remember that's only like a less than 1% chance. If you have a pregnancy whilst on the Mirena, there's an increased risk that that will be an ectopic, but that is still not a contraindication.
Any contraceptive we consider ectopic.
Well, exactly. So I'm still not sure why Manish puts that into the question,
She
but
doesn't want pregnancy anyway, then what, like, wouldn't the topic technically be better for her? 'Cause-
What? Did you just say wouldn't ectopic be better for
And
her?
then at least she doesn't.
But-
need to choose
but okay.
between-
Oh, she doesn't want pregnancy.
But
why
what
don't they
it-
make her pregnant?
But what it might be is that because she's only had an ectopic in the past, it might indicate that she has a nulliparous cervix, which means that it would be difficult and traumatic to get a myarina in. Or it could indicate, I mean, I'm clutching at straws here, that she might have an underlying structural abnormality, which is why she got an ectopic. Okay, so there's reasons there why you wouldn't consider myarina. The best being that she has a nulliparous cervix. So in that case, the best option for her is implanon. So that one. So implanon.
Because STIs are can't like a previous STI. No?
I don't think so. I'm not 100% sure. I don't know. But I feel like I wrote it. I feel like I wrote it in my notes somewhere.
I think they have PID with the IUD in, you have to remove it.
Something like that, yeah. That sounds pretty correct. Okay, so we have a 13-year-old girl. She has suprapubic pain, nausea with the onset of her menses. So we call this diagnosis is dysmenorrhea. So dysmenorrhea, not relieved by Panadol. So what do you give her next? NSAID. So what NSAID? So not that one. Mefenemic. Does anybody know the brand name? Ponstan. Okay, pretty common. Ponstan. Okay, so next question. So we have a young woman who is keen on gardening, pricked her little finger on the rose bush about a month ago, developed a fleshy lesion on the palm aspect of her finger. It bleeds easily, so she has kept it covered with plaster. Does anybody know what this is? Pyogenic granuloma. Now, do you know why that's the answer? Okay, you know what's pretty funny about this question is because I was looking it up on DermNet, and glomus tumor, is specifically in the description. It says is often secondary to getting a rose thorn injury, but it's not always related. And I just thought, are they like the meta is like deliberately trying to trick us? So the answer is pyogenic granuloma. So it's a relatively common. Okay, so very common. It's a reactive. So the reason so I'll just speak to you. It'll take too long to write. So the reason it bleeds so much is because a pyogenic granuloma is a proliferation of capillary blood vessels. So that's what it is. Often secondary to trauma, and it presents as this shiny red lump. So what you can see is it looks shiny, and it's also red, and it's also a lump. So it fulfills all of those criteria. A shiny red lump. They're completely benign, but they can cause discomfort and bleeding. So what's important to know about it is Staph aureus infection is often present at the lesion site. It can occur in pregnancy, so it can be due to hormones as well. And there's a lot of things it can do. But importantly, the reason it bleeds is because it's a capillary proliferation disease or condition. Nothing, it'll resolve by itself. Okay, 35 years old, a skin lump on the dorsum of her left foot, present for about a year, doesn't change in size, asymptomatic. She doesn't like how it looks, so wants to have it removed. So what do you think it is? It's a dermatofibroma, that's correct. So that's just a benign. So benign, it's a fibrous, it's a nodule. So it looks fibrous, it looks nodulistic. That often arises on the skin of the lower legs. So it's also in the correct location. So dermatofibroma is correct. So next question, we have a 65-year-old female, gradually enlarging. So that's important, that's very important, gradually enlarging. Skin lesion, that's correct, on in aspect of a thigh. So she has Bowen's disease. So what is another name for Bowen's disease? Okay, so yeah, I'll just say SCC inside. What is inside? What does that mean? So I drew a picture for you. So this is the epidermis, right? And this is the dermis, so two layers of the skin. So that's why it's called in situ, because it doesn't extend past the epidermis, but it can in the future. You never know. Whereas this is an SCC, which is invading down into the dermis. And this is solar keratosis, which differs from Bowen's disease because it's just a dysplasia of some of these cells inside of the epidermis. So Bowen's disease, very common. Okay, very common, especially in this age group, usually due to sun exposure. It can be due to ionizing radiation or HPV. So HPV causing Bowens disease is usually the Bowens disease that you find in the fingers and the fingernails, and also can happen in immune suppression. So what I was saying before is Bowens disease can turn into this in 5% of cases. So it can turn into an invasive SCC in 5%. And what is important to know about it on history, exactly as it says in this stem, it's a lesion that becomes larger over a few weeks with no history of trauma, and more common in the lower limbs of the elderly. So Bowens disease is the best answer. Okay, so this is just looking at, yeah.
One quick question.
You can make it long if you want.
Oh, okay. Well, Marjorie ulcer?
Yeah.
How is that different to Marjorie?
Marjorie is like it's an ulcer, so it's got a pit and it's like fibrable and big. Usually
Is that cancer?
It's actually, it's an
It's an
SCC.
SCC. And
Are they the
it's-
same thing?
No, I think it's usually a side. They're both SCCs, I think.
Yeah.
But margin is that side of like an old.
Oh,
scar
Hmm.
cut,
burn
yeah,
or
yeah.
something.
And it looks, you can tell it on the picture.
And then this develops de novo or?
Yeah.
Yeah, from sun exposure, from radiation,
Oh.
slowly growing, no history of trauma. But again, it's difficult to diagnose as well. Okay, so this is just everything, well, not everything else, but the things on the list that are important. So option A, so this is a so this one, so option A, so that's what the letters refer to. So this is an amelanotic melanoma. What does amelanotic mean? It doesn't have pigment, so it doesn't look black like normal melanomas, which makes it a diagnostic dilemma, but it is usually described as pink, red, brownish in color. And yeah, that's all. A glomus tumor is number E. Okay, so glomus tumor is a nodule. So you can see that there's a nodule that arises from the glomus cells. So glomus cells is a component of the dermis, so one of the special cells inside of the dermis that is, so glomus cells. So glomus cells, what they do, they regulate temperature. So that is why on history, somebody with a glomus tumor will often tell you it becomes more painful with changes in temperature. Because those glomus cells are important for temperature regulation, you can therefore understand why temperature changes causes pain. I thought that was very interesting, right? Okay, all right. So this is a keratocanthoma, so very, very common, especially in the elderly. So it erupts from sun-damaged skin, which is why it's happening on the ears, the face, forehead, scalp, those kinds of places. So it grows for a few months and then may shrink by itself, and it can't be reliably distinguished from more serious forms of cancer, which is why you need to look into it a bit more. Option H, so this is a neurofibroma. It's not neurofibromatosis, it's a neurofibroma. So a neurofibroma is a Schwann cell, okay? So if it's a Schwann cell, that indicates to you where is this occurring. So it's occurring along a nerve, right? Because a Schwann cell is what covers the nerve in myelin. So it's a myelin cell. So a neurofibroma occurs along a nerve, and it is cutaneous, is circumscribed, superficial, soft, is button-like, brown pink, and is this is what I was referring to, the pathognomonic. So buttonhole invagination. So when you press down on it, I didn't know, I didn't watch the video, but apparently it looks like something. So having a buttonhole invagination is pathognomonic for neurofibromas.
Is that how they tell the popcorn and banana type?
Yeah, I guess so. Yeah, reasonable.
Otherwise, it's the same.
They're not the, I mean, dermatofibroma was hard, the fibrotic, okay? Whereas this one is soft. Okay. All right. So let's look at this ECG. Okay. First of all, what do you notice? What is there two of? There's two QRS here, okay? QRS, another QRS. Let's look if there's any other abnormalities, okay? So there's an M there. It's not necessarily, okay, we'll skip that, okay. Atrial fibrillation, what you'd expect it to be irregularly irregular, which in this case is regularly irregular, okay? So it's not AF. And the other thing is that with AF, you would have no, which wave? P wave. Can we see a P wave here? Yes, we can see one there, so it's not AF. Is it atrial flutter? No, because they'd have a much higher rate. Is an atrial premature beat? Yeah? If it was a premature beat, what would you expect? An extra what? So you might expect an extra P wave, or you might expect an extra start of a QRS, but there's none of that there. But the thing is that atrial premature beat can look similar depending on how it can look similar in some situations, but I don't know the specifics. Okay, paroxysmal atrial tachycardia. It is not tachycardic. Sinus bradycardia. Is it sinus rhythm? No, it's not. So again, it's not sinus rhythm. It's not a heart block. Is it an SVT? It's not tachycardic. Is it VF? No. So even if you didn't know what bigeminy was, by process of elimination, you should be able to arrive at the diagnosis. And by looking at it, it makes sense. Bigeminy means two. So bigeminy, there's two QRS waves. So why does it happen? So bigeminy is, again, due to ectopic beats, okay? So ectopic beats. And what happens is that there's one, so I can't tell which one it is actually. But what happens is that after a sinus beat, so after you have a sinus beat, you have an extra QRS wave, which is the ectopic. So the ectopic is usually a premature ventricular contraction. So once you have the sinus beat, it's closely followed, as you can see here, by that ectopic premature ventricular contraction, so PVC. So the answer here is bigeminy. I don't know the management or anything else about it.
You can't really rule out sinus if you use CB. The previous means that it's sinus rhythm.
Bigeminy is the best answer. Okay, I don't know that much about ECGs. Okay, next question. So if we're looking at this, so first of all, lead 3, lead 2, what am I looking at? It has, but what does it have? ST elevation. Where else is the elevation?
AVF.
In AVF, where else?
That's not AVF.
Oh, whoops. AVF. Does anyone else have ST elevation?
V6, V5.
V6 and V5. Okay. So based on that, what do they have? Inferior lateral. Okay. So for those of us, including me, who wouldn't be able to tell that apart, let's have a look at a picture. Okay. So V1 and V2. So V1 is your septal lead. Okay. Now you might think, how's that a septal lead? It's not actually looking at the septum, but there's something about when the septum depolarizes, is at a perpendicular angle to V1, which is why it's looking at your septum specifically. Okay. So then V2, V3, and V4 are looking at your anterior wall. So that's why it's specific for that. Then V5 and V6 are looking at your lateral walls. Okay, makes sense? So that's why it's looking there. And then 1, 2, 3, and AVF are important to look at as well. Okay, next question. We're nearly there. So we have a 23-year-old woman, and she has a mid-shaft fracture of her humerus. She can't use her right hand, unable to pick up items, and hasn't improved. What does she have? Radial nerve injury. However, so that is correct. Okay, so when you have your bone here, so we know in the spiral groove the radial nerve runs. However, there's a few. I mean, just think about questions a bit more. So this question says that she's unable to pick items up. So usually when we pick items up, we need flexion in our hands, whereas radial nerve does our extension. Okay. Well, but to pick up an item, you need flexion and you need power of flexion to be able to pick it up. Okay. What I'm trying to get at is that the most common injury in the mid-shaft humerus fracture is definitely radial, undoubtedly. But the second most common is a median nerve injury that injures the anterior interosseous nerve, which would cause you to have weakness of your flexors. Saying that though, that still is, so radial is still probably the best answer, because as Roland is saying, to have a functional hand grip, to have a power grip, you need to have what's Newton's third rule? For every action, there's an equal and opposite reaction. So for your flexors, to have, well, maybe it's the first, it's one of the rules. So to have an optimal power grip, you need to have, what I'm trying to say, with your flexors, you need to have the opposite effect as well. So extensors as well. So that's why even if you have a radial nerve injury, you can still have weakness of your hand grip. So radial nerve is still probably the best answer, but there's still things to think about like that. Little ways that they try to trick you, or they try to trick me. They did trick me. Okay.
Oh.
Other thing is, I did overthink it, and maybe the other thing is maybe they have wrist drop. So having wrist drop from a radial nerve injury will also make it difficult to pick up objects. Okay, so 60-year-old woman, she presents with a claw hand. She has a fixed flexion deformity of the metacarpal phalange. So please look at your own hands and then look at where these defects are. So the MCP and the proximal, so the PIP of the middle, ring, and little finger. The DIPs are spared and there is no sensory loss detected. What does she think she has? Does she have an ulnar nerve injury? She has claw hand, right? Ulnar nerve. What does she have? So she has Dupuytren's, okay? So if whoever said that, that's absolutely correct. So Dupuytren's is, so if you remember back to the trigger finger that we we're talking about, Dupuytren's is a little bit similar, where you also have thickening of the palmar fascia and some of the tendons, and you have fibrous tissue forming, which makes it more difficult to flex your hands. So that's a Dupuytren's contracture, and you don't have a sensory loss, which is why they put it in there.
If there was any problem.
Probably not. Maybe. Yes, pterygium. That's correct.
We can go through.
No, try, we don't need to. That's
It's the end of
clear cut pterygium.
I didn't even see the question, but like.
Okay, this one is a bit more important. Okay, so we have 42-year-old man. He has intermittent trouble with sore eyes. He has recently flared up. Left eye is inflamed. Vision is normal. Fluorescent staining is negative. There's marked conjunctival injection and crossing of the lower eyelid margins. What do you think he has? He has blepharoconjunctivitis. We won't go into it because I think we've done opthal a lot, but we will go into a few things. Okay, so we have a young man, relatively some redness in his left eye when he woke up 2 days ago. Vision is normal. Doesn't feel any real pain, but there is a slight discomfort. Hemorrhage, correct. You can see that there. No management, it'll go away by itself. And this is this is everything else on that list, because I think it's important for you guys to at least see it. So this is allergic conjunctivitis with papillae. Okay, so this is papillae. Okay, so that's secondary to the inflammation. Okay, option A. So option A. I mean, without looking at I'm covering it up on my screen, thinking that you won't see it. So what is this picture? Oh, well, that's not a good color, is it? What is this picture? Yeah, okay. Posterior synechia is causing this bit. Because remember back in one of our other sessions, we talked about why iritis causes all of these eye symptoms. Okay? Because remember, acute iritis is a particular type of uveitis. Okay? The most common type of uveitis. The uveal tract is composed of 3 different things. Does anybody remember what they are? Ciliary body is one. The iris and the choroid. Okay? So this is called the vascular layer of the eye. So the eye is like an onion, like Shrek is. So it's the vascular layer of the eye. So when you have iritis, okay, so if I was to draw, how should I draw this? I'm not going to draw it. Okay.
How much of an artist?
Okay, so pupil is just a hole, right? And around it, the colored part is your iris. Okay, it's a circle. So inflammation, iritis, will cause you to have all of these different changes in your iris, which is why we get this abnormal shaped iris. Okay. Another thing you see with uveitis is hyperion. You guys have heard of that? Which is when you have the white blood cells that are located in the anterior chamber, because remember, it's an inflammation of that area and inflammation of the choroid. You can also have, what's the red blood cell one called? Hyphema. You can also get a hyphema. So that's iritis. Then number K, what is this? So that is a sty. So specifically, it's a meibomian cyst. Okay. Okay. So. Okay, well, look, the thing, okay. So styes are of 2 types, right? There's internal sty and there's external sty. So an internal sty is a meibomian cyst, so the blockage of the meibomian gland and having an infection there. Whereas an external sty is having an infection or blockage of the sebus or the sweat glands, which is called the gland of Sayce or the gland of Moll, respectively. So you can have it internal or external in both situations. Clasian. Non-effective. Yeah. Okay. So it'd be hard to tell on the picture alone. You kind of need a history. Okay. Option D. So option D is a conjunctival cyst. So you can see just a random cyst there. I don't know why they get that. Then keratoconjunctivitis is on this list somewhere, right? No, it's not on. Okay. So option J. So option J is a dendritic ulcer that is usually. So what is option J? So herpes simplex. So herpes simplex keratitis can give you a dendritic ulcer. That can cause ulceration, as you can see here. So this is after you give them fluorescein. So keratoconjunctivitis is important because it can be secondary to HSV, for example. But keratoconjunctivitis is just referring to a dry eye that is then causing the redness and the swelling. And the most common cause, well, not most common cause, but an important cause is vitamin A deficiency. So people who have keratoconjunctivitis can go on to have corneal ulceration, which is why I'm bringing it up. Other important causes are dacrocystitis. So who knows what dacrocystitis is? It's an inflammation, infection of your tear ducts, your lacrimal glands, by S. aureus, and that can also cause a keratoconjunctivitis. Okay, so nearly there. So we have a young man. He's going to Brazil Olympics. So therefore, what can't we give him? Beta blockers. Beta blockers. Because you don't want to give a high performance athlete beta blockers because it's going to slow down the heart rate. Or that. Okay, so relative contraindication. Okay. Is it?
Yeah.
Oh, okay. I didn't know that. Okay, he's generally very healthy. BP today is 166. Physical examination is normal. Okay, everything is normal. He was diagnosed with hypertension several years ago. Medications gave him a cough or ankle swelling. They interfered with his training. So what medication are you going to put him on? So look back at that flow chart that I showed you from the heart failure guidelines. What was the two medications we always give? ACE inhibitor plus diuretic. Okay, the ACE inhibitor had a very special symbol next to it, and that symbol was telling you this. So if they're intolerant to the ACE inhibitor because they have a cough, then change them to an angiotensin 2 receptor blocker, which in this case is candesartan.
Would you prescribe sartan for patients?
I don't think so. I don't know. I don't think so.
Because I think a lot of my GPs just like, oh, this medication is great. It's tempting like something sartan.
Well, they might, but I wouldn't know. I'm not sure.
Sartans are much cheaper now, anyway.
Okay, so it looks like we just skip a question. I bet. Okay. Anyway, question 47. So we have a young woman. She has frequency of urine polydipsia over 3 months. She drinks at least 1 liter of fluid at night when she wakes to empty her bladder. So when she wakes up at nighttime, she drinks 1 liter of fluid. That's interesting. She's only recently become sexually active, so it's not an STI, it's not a UTI. Urine analysis shows low specific gravity, which isn't really telling you anything. BP, electrolytes, creatinine, and plasma osmolality are normal. That rules out diabetes insipidus. So what do you think she has?
Oh, wait, up the urine.
Okay, so there's a few. Okay, chronic renal failure. No. Okay, because creatinine is normal. Diabetes insipidus.
No.
Osmolality is normal. Okay, diabetes mellitus. Maybe. Okay, hypercalcemia.
Electrolytes are normal.
Yeah, it's same. Again, electrolytes are normal. Normal. Okay, I don't even know what that is. Urinary tract infection. Again, no. Okay. So what does she have? She has polydipsia, and she has polyuria, which makes diabetes mellitus very likely. That's correct. Now, the other thing is that some people consider whether psychogenic polydipsia could be diagnosis. I mean, psychogenic polydipsia, first of all, is rare. Second one is usually associated with people who have severe mental illness, which seems unlikely in her case. So, yeah. So I think we'll leave it with diabetes mellitus, maybe, and we'll also consider whether that could be the answer.
Milturia makes diabetes.
Glucose in the urine, right?
Yeah, and polyphagia.
Polyphagia is.
Does it say the urine is normal? Oh, yeah.
It says,
Let's go psychogenic then.
yeah.
Psychogenic.
She says she's needed to take, as in, like, she feels
Like
compelled.
she feels compelled, which is why I was leaning towards that answer, but I wasn't 100% sure.
What did you
But-
end up picking?
I did pick psychogenic, but then when you guys are talking about that, maybe it is diabetes. Yeah, wasn't it? Yeah, true. I think psychogenic probably is the best answer for this question. Okay, so 60-year-old, increasing fatigue, anorexia, worsening cough, polyuria, thirst, collapses in surgery because he has ECG abnormalities. What does he have? Is it clear and cut?
Hypokalemia. Hypokalemia.
Hypercalcemia. That's correct. Okay, it is hypercalcemia. Okay, so you can have hypercalcemia. So apart from PTH, so Ca2 plus. Okay, so apart from parathyroid hormone, which is the most common cause of, in general, for hypercalcemia, the most common cause is malignancy. Okay, hypercalcemia of malignancy. Okay, so there's 3 ways that you can get this. All right. So number 1, 1 second. Okay, so the first one is humoral. So humoral hypercalcemia of malignancy. Okay, so this is due to from any cancer that releases parathyroid hormone related peptide. So this is usually from solid cancers, so breast, ovarian, liver, prostate. Okay, so those things will cause you to release this, and that is somewhere in the realm of 80% of cases of hypercalcemia due to malignancy. Okay, so then the second cause, okay, is osteolytic. Okay, so what does osteolytic refer to? So breakdown. Okay, so breakdown usually from what? Multiple myeloma or METs. That's exactly correct. And then the third one is all types of random stuff. So, for example, you can have ectopic secretion. So as we know from a small cell lung cancer, you can have ectopic PTH. Ectopic secretion, you can have vitamin D toxicity in other, for example, usually lymphomas do that. So 90% is due to malignancy. Is due to these first two causes, and the last 10% is due to that. So apart from having hyperparathyroidism, the most common cause of hypercalcemia is malignancy. Other important things to know about hypercalcemia is not how high your calcium is. It depends on how quickly your calcium increased. That will dictate what kind of symptoms you get and how you need to manage it. What I'm trying to say is hypercalcemia is usually asymptomatic, no matter what. Well, it does depend on the level, but usually asymptomatic. But if you have a sudden increase, that is when the patient gets the stones, burns, groans, turns, moans, jones, learns, turns. So they get all of those different things. So in this case, he has polyuria and he has thirst, which refers to the thrones. Okay, throne. Well, first different things. Thirst. Okay. Psychiatric. All those things, because calcium is implicated at the action potential, which is why you get all of these cranial side effects, which is why you get the changes in your psyche and why you have changes in your heart rhythm. So hypercalcemia is the best answer for this one, especially with a history of fatigue, loss of weight, and worsening cough. Okay?
Cool. Nice.
Oh, you made it.
Smiley face, please.
Only 21 minutes.
I'm sorry, Nicole.
Good job.
Okay, thank you, everyone. Oh, I swear we were going to finish early today, but we did last week. In my defense.
Just make like a betting game.
Well, Alice is not past 8 today. So next week, I really want to try and compel somebody to do it instead of me. But if not, we'll just go on with the second half of the paper.
I don't think you'll succeed.
And I'll see you guys then. Again, thank you so much always for being so prepared, having so much knowledge, pointing out the mistakes, because it helps a lot, even for my revision. So please continue to do that. Forgive me for the mistakes that I make. I try my best, and I'll see you guys next week, hopefully.
Thank you.
My pleasure.
Taha, do you want to come get dinner with us?
Sounds like a plan. Oh, but crap, but I need to do my women's health quiz.
Women's health what?